So we have been talking about systems change and how do we change our system, and we've been doing this work for 20 years in relationship actually with all the partners represented here. And an opportunity came up through the Office of Women's Health and Department of Health and Human Services to apply for a grant on a ridiculously short time frame. And the city and everyone said, you've been trying to do this work for 20 years without funding, so you have to apply for it. I thought everyone would say no. And I think because of these long-term relationships with all of the organizations represented on this panel, we presented a really strong partnership grant to the federal government, and we're funded to do this work. We're just in the process of hiring now, so we haven't moved forward. So the grant is called ARISE, and the next one. And it's funded for 3 years. And the federal impetus, we talked about the fact that policy change is really important to drive this work forward. And the impetus for this on the federal government's basis was the Affordable Care Act, which actually mandates that all health plans must offer interpersonal violence, which they say intimate partner violence and sexual assault. We include reproductive coercion in that. Must offer education, screening, counseling, and referral as a free preventive health service for all women and girls. And I just want to acknowledge my colleagues. Eddie Machner is a co-investigator on this, as Hayes Bakken in pediatrics and Dean Schillinger in Department of General Internal Medicine. And so really at its core, this is a partnership grant. And what we've been talking about today is really a lot of both the failures of the healthcare system and the opportunities of the healthcare system if we understand how to partner well with community-based agencies who have been working with survivors of violence for decades and have incredible lived experience. And so this is a partnership grant to bring together worlds that for survivors of interpersonal violence do not necessarily work together, have not necessarily worked together in the past. So our ARISE partners, and this list is actually growing as we start this work, but these are the partners that we started with when we applied for the grant. At UCSF, the Department of Public Health, and really important, that's where our work is all based, is in all of the primary care clinics for the Department of Public Health, all 17 clinics throughout the city. La Casa de las Madres, also represented on this panel, Bay Area Legal Aid as well, Trauma Recovery Center, Futures Without Violence, which is a national nonprofit international leadership organization around violence prevention. California Healthcare Safety Net Institute, to actually try and intentionally have a dissemination partner from the beginning of this process to disseminate this work through all public hospitals in California as we do the work. Instituto Familiar de la Raza, from whom I feel like I learn something every single time I interact with them about oppression and about the original evidence-based practices for trauma, which are thousands of years old, and then the Child Trauma Research Program and the Women's Education Program at UCSF. Again, our hypothesis is that there will be not one thing that you need to do to empower and improve safety for women and girls who are experiencing interpersonal violence, but that there will be a whole host of things that you need to do in order to address especially highly vulnerable patients who are suffering from all the social determinants of health that we've been discussing, and that the way to do this is through the healthcare system partnering with community agencies, and the way to do this is more intentionally paying attention to a panel management system where we would actually know how many survivors we are trying to help and reach out to them regularly and where we would have a multidisciplinary team that actually looks at what are the structural barriers for people improving their safety and increasing independence and empowerment, and we would look at that every single month all together in partnership with all of our partners and figure out like how can we constantly course correct and improve what we're doing. And so this is really coming at a critical time in the Department of Public Health's history, in which Ken will talk about the trauma-informed systems work, but this really is occurring at the ideal moment when the Department of Public Health is committed to these two huge initiatives of trauma-informed systems and cultural humility. And every single training that we're doing, the federal government did not actually put the words trauma-informed care in the request for proposals, but we are committed to every single time we do training about this project, basing our work in trauma-informed care and in these initiatives. And again, they're in the 17 clinics. So we have a sort of natural experiment in San Francisco based on geography. I tried 20 years ago actually to partner with Casa Madres at Maxine Hall Health Center, where I worked for 20 years as a primary care provider, and we didn't actually have the volume of patients on any given day in order to make it worthwhile for an advocate to sit with us in clinic all the time. And so as an initial step, and I really want to stress that this is an initial step, we are using the fact that we have 5 campus-based clinics that are probably going to have an incredibly high level of number of referrals to an interpersonal violence advocate in the hospital, to do a sort of quasi-experimental design of different levels of intervention throughout our primary care system. So in all 17 clinics, we will improve our education, doing preventive education so that people don't actually need to disclose violence in order to get assistance. So preventive scripts where they know how to get help even if they choose not to disclose. We'll be doing screening, brief counseling, and we'll be improving our behavioral health, integrated behavioral health, safety and empowerment counseling model, and that will be at all the clinics. And then in the hospital-based clinics, 5 clinics, we'll be adding also a warm handoff to a La Casa de las Madres advocate who is going to be based at the hospital and available to run down or up or wherever to clinics and actually meet with patients right then. And then in one clinic, we know that will be way more than we have now, but it still will not be enough to help people achieve the optimal level of independence and fulfill their wishes for what they want for their life. So in one clinic, in the pediatric clinic, which is a really incredible place to do this because everything we do for parents will prevent exposure for children to violence, we are going to additionally add multiple other partnerships. So Bay Area Legal Aid will be providing, Jamin will talk about that, we'll be providing legal advocacy and consultation. The IPV advocate will be coming, we'll be doing a sort of outreach and panel management. And then we all know that our system does not work well for patients who have a really high lifetime burden of trauma or are suffering from PTSD and complex PTSD, and that in fact our healthcare system is very triggering for patients who have a really high lifetime burden of trauma. And so we're partnered with the Trauma Recovery Center to actually advise us on our model, as well as receive expedited referrals for patients who have a really high burden of trauma. And as I said, that this is a research study as well as an implementation study. We can answer questions about that later. And then, so just thank you to our partners, who I'm really happy to be here with. And I'm happy that actually based on 20-year relationships, people were willing to take a chance on a untrauma-informed grant writing process. No.
Hi there. Really happy to be here today and so appreciate all the work that everyone's put in to create such an intentional day. It's been really inspiring to be here, and happy to share a little bit about the Trauma Recovery Center, also known as TRC. So basically, we're an outpatient mental health clinic that provides trauma therapy and support for adult survivors of trauma and violence in this city. And we were initially created over 15 years ago as a pilot program with the intention of a lot of the doctors here at San Francisco General were seeing the same patients over and over again in the emergency room. And although they felt able to help patients heal physically, they didn't feel able to address the emotional and other tangible factors that were putting folks at risk of re-victimization. So the TRC was initially developed to remove barriers to people accessing mental health support services. And the goals of TRC are basically to offer early intervention for survivors, also to engage folks who might have difficulty accessing more traditional mental health services. We have a really assertive outreach model, meaning that we'll come to the hospital to meet with a survivor for the first time. We'll go to their home if they're too injured or too traumatized to be able to come to our clinic. So we really try to remove barriers related to accessing our services when it comes to providing them. We also do a lot of research and evaluation to look at treatment models that are most helpful to victims of crime, and then also do a lot of community speaking events and trainings and education within the community. And at this point, you can kind of think of Trauma Recovery Center as sort of an umbrella, and we have a bunch of different programs that are under that umbrella. So first, there's just the services that are kind of what we mostly talk about, the services for victims of violent crime. But we also are the Rape Treatment Center. So we respond here to San Francisco General with medical providers and with social work staff to support people after a sexual assault. We also recently took on the Survivors International program, which has been really, really exciting. So now we're able to support survivors of torture and provide them mental health services and support, and also do some asylum evaluations for them. We also have a traumatic brain injury program that works closely with the neurosurgery department here. And then recently we've started collaborating with the Women's HIV program at UCSF. So those are our initial services. Oh, did you? Okay, thank you. So the overall goal of our services is really to offer early intervention for trauma survivors. And the first step to accessing services with us is what we call an intake assessment. And it's basically a comprehensive psychosocial evaluation. And I like to tell clients that it's not just to hear about the trauma that brings them to us, but we really want to understand how that's impacting them, and then learn about other parts of their lives, because we know that there's so much more to their stories than the trauma that brings them to us. From there, basically, if somebody is still interested in receiving services and they're eligible, which I'll talk about in a moment, they're assigned a therapist to meet with weekly. And we have a short-term trauma-focused model. So that means that our initial contract is usually for 16 sessions. And sometimes we can extend that. But really our intention is to be there sort of in that acute phase after trauma. And we often refer people to longer-term care after that. We also have some group and family work that we do. So we do have a seeking safety group. We're going to be able to offer a STARE group for affect regulation soon. We have a speakers bureau that I co-coordinate, and some other various groups. I think we have a group for family members of homicide victims and an anxiety support group as well. We also have 3 psychiatrists on staff. I think they, in total, work about 3 days at the clinic, but it's really wonderful to have them there, and we're able to work as a team to really support clients both with the therapy and then with psychiatric medications when needed. And all of our services are very, very voluntary, so really trying to empower clients to take this step and to support them in receiving treatment, and reminding them if it isn't for them, that that's okay too, that we'll still be there later. And then in terms of eligibility for our services, just wanted to give you guys a brief overview of that. So first off, must be an adult over the age of 18, must be a San Francisco resident, can't have another mental health provider, and that's a therapist, a psychiatrist, or any master's level case manager. We really don't want to duplicate services. We also really don't want to get in the way of long-term treatment that may already be supporting somebody, given that we're a short-term model. And then must want to focus primarily on recent trauma, and that's generally within the last 3 years. And then in terms of who can refer to us, so we can only take referrals from specific spots. San Francisco General is one of them, as are all of the Community Health Network medical clinics. Also, we can take referrals from the Victim Services Office here in San Francisco, from all of the local domestic violence agencies, and now from UCSF Women's HIV Program. And this is just the contact information for how to reach us. And basically, if you want to make a referral, we just ask that you give a call to the main number. You can ask to speak to what we call the building officer of the day, and that's somebody who's always available to take referrals. We do prefer that you call with the client. We find that just engaging them in services, it's a lot easier if we have that conversation with the provider and the patient present. And generally there's somebody available 8 to 5 to be able to speak with you. So feel free to give us a call, and we're also located about a 15-minute walk from here.
Thank you. So next we have Dr. Ken Epstein.
Good afternoon. I'm not very good with slides, so I'm going to do my best, as you can see. I actually wanted to start a little differently than I had planned. I wanted to thank Gina, Nana, and Linda. Even though you've told your stories to many, it was the first time I had heard your story, and I feel profoundly changed today listening to those stories. In fact, it sort of frames a lot of what I think we're trying to do, and I feel really humbled to present. I also feel humbled to sit with the providers in the room, Lee, who's been a mentor to me, and Eddie, who has done so much work directly, and everybody else on this panel. I was really listening to the story of the blind therapist who could see, and the nurse that knew how to touch. And I was thinking about how much they're the exception to the rule, unfortunately, as opposed to the rule. And I think probably many people in this room are also the exceptions to the rule, as opposed to the rule. But unfortunately, the rule in our system and embedded in those stories is how much was missed. And I was so touched by just how many times I hear of children who were then adults saying, all I wanted to do was for someone to ask me what was wrong. You know, how many times are we going to hear that over and over again, and having not asked what was wrong? It's such a simple question, and yet we are somehow, as professionals, unable to ask or listen to the answer to that question. So I think what today is about is maybe talking a little bit about how did our delivery systems get this way? I think Eddie said something about SAMHSA's definition about trauma being, as opposed to what's wrong with you, what's happened to you. And at the Department of Public Health, I think we began to ask ourselves the question, what happened to us? How did really good people, really mission-driven, really well-intended, end up in a system that replicates such horrible outcomes for some of the folks that we care the most about? And I think that's a really challenging question that we have to reflect on a lot, because often what happens is we reel out the statistics and the evidence and the facts of what's happening here in San Francisco that's not different than other places to the African American community and other communities of color through, yes, structural and historical racism and issues that have led to really, in the wake of all of this evidence, have led to really decreasingly and increasingly worse outcomes. And we have to ask ourselves the question, and the answer is that there's something happening in our delivery system. So I said some of this to Barbara Garcia 2 weeks after I started work, and she assigned me the problem. So I'm a family therapist and a systems therapist, and I've been here for 4 years, and this is the largest system I've ever had to work with. So what you're seeing now, I can click that. I'm not nervous anymore. Okay. So what you're seeing now is what happened from that conversation. I am humbled by her asking us to train the entire department of 9,000 people. Actually, she first told me it was 6,000. That wasn't calming either. So what we did is we went out actually and we consulted with people like Lee and 250 or 300 other experts and people from the community with lived experience about how best to train a department. And what resulted were, which you've already seen, is these 6 principles. I'm not going to go through all the principles. Certainly when and if you come to the training, we can talk about them more, but they were both stolen shamelessly from other places across the country that are also doing this. The state of Maine, a town in Florida called Tarpon, Florida, the city of Philadelphia with Sandra Bloom's incredible sanctuary work, in San Diego, but really not very upstate New York, but not very many places had attempted a system-wide incorporation of trauma into the system, not treating the people, but treating the system. And that's what these principles are talking about. In the center, you can see practice. And then outside that, we're looking at policies and procedures and leadership. So on the slide, you see where we started. This is our interpretation of what a trauma-informed system is. You can see that the symptoms that we were talking about before, the reactivity, the reliving and retelling, the avoiding and the numbing, and the fragmentation, these are all things we put into people. But in fact, if you work for the Department of Public Health, you experience these things every day. You experience it if you're a bureaucrat, you experience it in an email that's CC'd to 6 other people that you spend 3 hours trying to fix because somebody emailed emotion, right? You experience it in meetings that start without a check-in and people are dissociated as they come in because they were just working with somebody who'd been traumatized or something that happened, and the meeting starts with outcomes and statistics and outcomes. And who said before, it was just said before, I was so touched by that idea that in white supremacy, I think Nana, you said it, in white supremacy, we're all about the outcome as opposed to the process. How many meetings have we been in where we didn't really check in with each other and see how we're doing so that people can listen? And how inefficient is that actually, to know that I'm disassociating in my meeting? And how many meetings are we in this day where people are on their devices? Because really that's calming to us. I do it, we all do it, we're doing it now. I'm not saying that it's not an important function. But if we're talking about people and places and these kinds of things. So in a trauma-informed system, we're thinking about what we're living with every day. And we live in a trauma-inducing system. So when we started the Trauma-Informed Systems Initiative, we thought, okay, we want it to be trauma-informed, and that would be a trauma-reducing system. And so a trauma-informed system has a shared language. A shared language is our 101 training, in which we train our folks, 9,000 of them, 3.5 hours, in a common training with those common principles. Somebody said before, it's about teaching empathy, and more. But it is about teaching what Eddie said about the broken relationships that trauma causes, and really getting us thinking about how relationships are healing. And then leading towards a healing organization. This is the part, I'm humbled to say, we have learned how to do the train and pray method. Do you know what the train and pray method is? Can you guess? It's what I'm doing today, actually. I'm telling you about this and I'm praying it's going to be important to you enough that maybe you'll do something about it. That's what we do a lot. We train people and pray that the behavior will change. But we know from implementation science that actually behavior doesn't change from training. So what we do that's unique in the training is we go through the 3.5 hours. We have a train the trainer program. We've now trained Katie, 16 folks as train the trainers. So we started with 2. We now have 16 people that can stand and deliver within the department. This is not something, by the way, that we bought from some other place or space. We can sustain it within our program, and really the resources are sitting in the back of the room. That's Katie. We're a department of 1, maybe 2. And the great thing is that we now have 16 people whose job it is to train within our department. At the end of the training, who's been to the training? Okay, so you know at the end of the training we're at 3 times. Oh, man.
I love it.
That's cool. So you've done 3 commitment to changes? You're very busy. So at the end of the training, as you know, we ask for a commitment to change, and that's our sort of transition to, okay, you're sitting here and listening and doing exercises, but can you really? And what's exciting about the commitment to change is actually 80% of the people in follow-ups are doing the commitment to change. Most are either successful or partially successful, and some have actually not been able to do what they committed to. But that's pretty good to have 7 or 8 out of 10 people taking a training and then trying to do something with the data. The real hard part is the last slide, which is the last part of the slide, is becoming a healing organization. And that's really what we're talking about today. And how do we move from a training, something that's trauma-informed, or whether you want to call it a resiliency-based organization, whatever word you want to do, you're switching your understanding of trauma in the organization to something your organization is due to healing. And that organization looks differently, and that's what we're beginning to test now. We got a grant from Robert Wood Johnson to develop a leadership and champions group. So we have maternal child adolescent health, your ICAP program here, the juvenile probation, Department of Children, Youth and Families, Children, Youth and Families myself, and Laguna Honda, are all participating as leaders in a learning community about how do we lead from a trauma-informed systems perspective, and we will develop with the grant a leadership toolkit. But it's not just about the leaders, because embedded, the leaders have picked champions who then can teach and embed these practices within their units. So that's us translating the train and pray method into a do and change method towards a healing organization. Did you say I have another slide?
Yeah.
And this is just what I've said. So you can see these are the components of our workforce. So we start with the workforce training, the 101, the train the trainer, the champions, and the leadership. Alignment is really important in Department of Public Health or in San Francisco, because as you know, we're a city of initiatives on steroids, right? So even getting in people's brains and staying in people's brains is a challenge. If you're in our workforce, every day you get a new email about a new initiative that you're trying to remember yesterday's initiative. So a lot of what we do is, and one of the things I want to say is in our evaluation, and I probably only have a minute, right? Is that right?
Right.
Okay. So I'm going to say this very quick about evaluation. They love it. The one thing I want to say about evaluation is that the staff have told us really loud and clear that they like the Trauma-Informed Systems Initiative and they think it will go away. They think it will go away because initiatives that are good go away. So I'll just stay in my place and I'll wait for the next one. So that's why it's important for all of you to join us so that it's not Ken's or Katie's or Barbara's initiative, and why we're so proud and happy of HIVE for doing this training yourselves. And I just want to encourage you, if you have any questions or ideas, or you want to get involved, to contact us, because if we're to be successful, this will become part and parcel of what DPH does, and initiatives like Lean, which we've been trying to work with and align ourselves, or relationship-centered communication, service excellence, and I could go on and talk about all of them that are trying to transform our system. Can we align those initiatives so that they're understandable to our employees and don't seem like they'll go away tomorrow? We do have an evaluation which I'll leave with HIVE, and we can put it online, but this is our evaluation booklet, so I'll leave it with you all.
Thanks so much, Ken.
I'm the social worker with HIVE, formerly called BAPAC. I've been there 12 years, 12 really beautiful years for me. You guys already heard the mission and the vision of HIVE. That's what it is. We're a small group of providers who are all really fiercely committed to what we're doing and to the women and couples and families that we're working with. HIVE has 2 components, being the clinic and then the education work we do. The clinic is based here at San Francisco General. We were founded and initially provided prenatal care to HIV positive women, and we continue to do that. We have, it's kind of our core service, and we are able to provide, to do it well. We haven't had a transmission mom to baby since 2004, continue to be really proud of that work. But our work also has grown over the years, and I think one of the things I feel most proud of is the work we've begun to do in recent years around preconception, and that I think came kind of, if I speak a tiny bit about it, we had a lot of women come to us or refer to us with unplanned pregnancies, and when we would get in the room and we would talk about their pregnancies, they were actually quite not unplanned really. They were much like wished for and desired, and it felt like we heard a lot from our patients that they felt like they couldn't tell their doctor how much they wanted to become pregnant or how much that was their goal, and then they couldn't because of their HIV or in some cases their partner's HIV, that it had been taken off the table as a choice that they could make, and we wanted to change that, and so the piece in recent years has been getting our name out to all of our partners, the idea of referring, of asking your positive women if they have, and men too, if they desire pregnancy, and then connecting with us early, because there's so much beautiful work to be done around just improving their health, that woman's health, that couple's health in anticipation and preparation for a pregnancy. And that is the work that we've been doing more recently that I feel very proud of. Additionally, we work, traditionally we started working, just with HIV positive women, but work more now with HIV negative women as well in positive partnerships, and some and just at risk because of partners with unknown status. We've moved on. Okay, well wait, I want to say one other thing from the clinic, which is that, so we provide all that clinical care that you see and the social services, but I think really where the magic happens in our clinic is in how much the social services and the medical care are unified and work together. And so in the form of a weekly case conference, me, the social worker, and the medical providers kind of come together around what's going on with that patient and what's been going on for her since we last saw her, and what, including the new stressors, including the new victories, and things we want to help her celebrate with her. And that, so we're all working together each week with our patients. Okay, now you can go to the education. So the other bit of HIVE is all that you guys have probably seen on the website, which is so incredible. And that is about disseminating information and diffusing it and getting it into the hands of people who need it, including medical providers who are taking care of women with HIV or affected by HIV, but also into positive women or negative women with positive partners. And one of the great, I wish for all of my positive women to know another woman or go to a group or be in community, but not everybody is ready. And one of the incredible things from the website, the work on the website in the past few years, is that we're able, for the women who are not ready, to still share stories, through the blogs, through the videos, to still expose women to the voices and the stories of other women.
That's a chair over there. So I am a staff attorney at Bay Area Legal Aid. I am stepping in for my manager, Gerald McCrary, who was supposed to be here today, but was impaneled on a jury late last week, so he unfortunately had to miss this event. So I'll start with talking a little bit about Bay Area Legal Aid. We are the largest civil legal services agency in the San Francisco Bay Area. We have offices in Alameda, San Francisco, Napa, Contra Costa, and San Mateo, and Santa Clara. We receive funding from multiple sources, including the Legal Services Corporation, which was established by Congress to provide financial support for civil legal aid for low-income Americans. We provide legal services in the areas of housing, health access, public benefits, family law, immigration, and consumer law. And we have several projects geared toward working with specific populations to provide an array of legal services. We have a youth justice project, the Legal Barriers to Employment project, a reentry project, and the medical legal partnership with the Children's Health Center and the Family Health Center at San Francisco General. Our services are free for low-income Bay Area residents. We screen for income eligibility, so we serve people who are at or below 125% of the federal poverty levels. Sometimes with certain exceptions, we can go up to 200%. We also screen for conflicts of interest, and we screen for immigration status. These eligibility guidelines are requirements from our funders. And the immigration status requirement is waived in cases where we work with survivors of IPV-DB. And this is one of the few areas where we are able to serve undocumented immigrants. Persons seeking Baylegal's help access our services by calling our legal advice line. The phone number is available on the flyers. And the legal advice line is staffed by attorneys. These attorneys will conduct the eligibility screening, and they will triage the cases, deciding whether to schedule the case with the local office or to refer out to another organization. Our legal advice line has been especially busy recently, so anyone referred should be advised ahead of time that there could be a long potential wait time. I run the medical legal partnership with the Children's Health Center, and we provide basic legal trainings to the medical providers. We screen for health-harming legal needs, and we take referrals from the medical providers in Baylegal's substantive practice areas. And I'll talk a little bit more about our work, our immigration work. We mainly do U visas, which are something that encourages survivors of domestic IPV and certain other crimes as well. It encourages them to cooperate with law enforcement and actually report the crime to law enforcement. And if they are undocumented and they cooperate with law enforcement, they can apply for a U visa and have the law enforcement agency sign a certification for them that they can attach to the application. And it is one of the few ways in which someone who is undocumented can become documented. Yeah, that's it.
So La Casa de las Madres, the mission of La Casa de las Madres is to respond to calls for help from domestic violence victims of all ages, 24 hours a day, 365 days a year. We give survivors the tools to transform their lives. We seek to prevent future violence by educating the community and by redefining public perceptions about domestic violence. And this year is our 40th anniversary, so we're going to have a big kickoff in Domestic Violence Awareness Month in October. It's our big fundraiser. Now you can go to the next one. So another definition, just so you know, domestic violence is an escalating pattern of abuse and violent behavior that a person uses to exert and maintain power and control over another person with an intimate relationship. So this is kind of what our focus is on: domestic violence, intimate partner violence, escalating pattern, right? Domestic violence doesn't get better over time, it gets worse over time and gets more violent over time. And this is all of the services as of right now that La Casa provides. Sorry if it's a little bit small to read. So we have a 24-hour crisis line. We have a trained crisis counselor, usually a case manager or family advocate on the other end, 365 days a year. Someone will answer the call. We can provide counseling, referrals, resources, also do intakes for our shelter or set up counseling appointments at our drop-in center. Our shelter program, so we have a shelter which is in a confidential location, of course, because of safety, which houses about 35 to, that's supposed to be our max, but sometimes we go up to about 45 women and their children for up to an 8-week stay. So there we have clinical interns to provide counseling, case management, groups, support groups, kind of a whole range of things, because 8 weeks is not a long stay, so to help our clients get back up on their feet and to make the transition from shelter to whatever their next step is. And our drop-in center is our main office as well, which is down on Mission in South Van Ness. And there we provide one-on-one peer counseling, therapeutic counseling. We have 4 support groups, 2 in English and 2 in Spanish. We have a legal services manager who helps with restraining orders, kind of a big, comprehensive, wide range of services that we provide at our drop-in counseling center, and that's also where our administrative offices are. We have a teen program And we have a teen advocate that goes out to different high schools and really talks about healthy relationships and what it's like to be in a healthy relationship. We really want to start kind of when people are young, right? So starting with the teen population, letting them know red flags of violent relationships and what healthy relationships looks like. And now there's a whole thing with cyber abuse, which is kind of new to me, but we have to really look at our teens for that and know that it also is domestic violence, right? We have another new program starting up in the Bayview Y. We're going to have a case manager there 2 days a week who's going to work with first responders and help them seek safety and shelter, or help the victim seek safety and shelter. We have a community education. So we go out into the community and educate different CBOs and different agencies on domestic violence, the cycle of violence, domestic violence in children, domestic violence in mental health, whatever that organization is looking for. And we don't just work with nonprofits or other CBOs. We just did a training with Salesforce, Twitter. So, domestic violence can happen to anyone. It doesn't matter what your socioeconomic status is. So we try to get out there, put our voice out there, give a voice to victims. We have a advocate at 850 Bryant who works with victims who come into the police station, referring them to our drop-in center, referring them to our shelter. We do have 2 beds at our shelter, which we call them divert beds, where someone referred by the police department can stay there 1 or 2 nights to seek safety and then get transferred to another shelter. Safe housing, we have 2 advocates at San Francisco Housing Authority, which provides case management to residents that live there who are victims of domestic violence. And then, of course, the RISE program, which seems like a great program, and I'm really excited. And then, I think that's my last slide.
So this question is for Lee. So it's important that, and we've talked about this, we've touched on this today through all of our previous panels, but it's important that disclosure of IPV to a provider happens in a safe place, physically and emotionally. What work are you doing, will ARISE do with collaborating with clinic, hospital, security, in ensuring the safety of patients, providers during these visits?
First of all, I'll discuss in the IPV workshop that actually our goal now, because we know disclosure rates are, of course, not very high in a lot of settings, and that there are a lot of very, very good reasons why people might not want to share what's happening to them. So one big part of this grant will be how do people get help without necessarily disclosing, so universal education. So we'll be training the healthcare teams to do universal education. So that'll be one thing that people will choose whether it feels safe to them or not feel safe to them to say anything. And I wish that we could have started out the grant that way, where people could self-refer to the La Casa advocate without actually having to disclose to the healthcare setting. Of course, they can call the hotline without disclosing, and we encourage people to do that. But just for making it a trauma-informed process for the advocate who's starting, we didn't want to open the floodgates that anybody can knock on the door before we have a more organized system. So it will involve systems change work. You mentioned security. You mentioned various different aspects of our hospital system. We'll need to all work together to work through really specific protocols about how we will handle disclosures, because as we learned with the case that started this whole situation, this whole dialogue, different professions have different approaches. We all want safety for people, and we all want safety in society, but different professions have different approaches to disclosures. And so we need to negotiate, like, how is that going to work in our hospital system?
I think one of the things we know from data is that if I meet with somebody and give them a card and tell them to go see somebody, there's a 20% chance they'll actually go. So I think one of the things our system has to work on is two things. One is everybody that somebody meets needs to know how to have a relationship and ask them what's going on with them and feel comfortable with the answer and sit with them around the challenges. And I think as we're trying to work, we need to make sure that in all the settings that women are showing up, as I think we're talking about today, there are behavioral health professionals in that setting next to them that can help them in the setting that they're in, as opposed to sending them someplace that they're not going to go.
Yeah, so the whole purpose of the grant will be that the integrated behavioral health clinician will feel very comfortable supporting the provider if the provider doesn't necessarily completely know what to do, and that the advocate will actually come in person to meet with the patient, so that we will not just be handing a card to people.
Yeah, I was wondering more about like resources to build the capacity of the organization. Like in the East Bay, for example, where we
Yes,
don't
I think
have
I would
all
say, I mean, I have some things on the LEAP website that I think are helpful, and I think that the main source to go for that would be Health Cares About IPV, which our partner Futures Without Violence has a whole toolkit website called Health Cares About IPV, and it actually shows little 5-minute, 2-minute videos about how to talk to patients about this and how to handle disclosures, and has a whole toolkit as well. And there are great safety plans on the LEAP website that if you don't know what to do once a patient discloses, we have them in 9 languages. You just walk through the safety plan with a patient. And it will guide you, the safety plan guides the provider as to how they should be responding, even down to acknowledging conflicting emotions and feelings is actually part of the safety plan.
And actually those resources are listed in your packets in the back as well. So we're actually at time for lunch. I'd like to introduce Silvi up to the front.
To become a healing organization, arise, find partnership, give access, offer early intervention, educate, care, remove risk of re-traumatization, investigate treatment options, work as a group, a family, offer autonomy, improve safety and empowerment, put principles into practice, work toward recovery, remember to treat the system as well as the people, support, study, teach, sustain, train, practice, share language, speak empathy, make meaning of the past, practice compassion and dependability, cultural humility and responsiveness, be a refuge, an advocate, a strong voice, be the nurse who knows how to touch, be the blind therapist who knows how to see, be the professional who asks what's wrong, make the commitment to change.